We welcome you to Infectious Insights, a case series designed to discuss challenges and offer solutions for difficult-to-treat gram-positive bacterial infections. Would you speak a little bit more about the mechanism of action of telavancin?
Sure. Telavancin, as we know, has a mechanism of action somewhat similar to vancomycin in that it inhibits cell wall synthesis, peptidoglycan synthesis, transglycosylation. And it does this in a much more potent fashion than vancomycin itself. So it inhibits that cell wall synthesis, but it has a dual mechanism of action. It has concentration-dependent bactericidal activity, and there's a lipophilic tail on the structure of telavancin, and that tail allows this molecule to have a bactericidal effect because it interacts with the cell membrane. So it depolarizes the membrane of the bacteria, destabilizes it, changes the permeability, and this all results in a rapid bactericidal effect, a long post-antibiotic effect, and those two mechanisms combined are sort of synergistic in their pharmacology, and that's what separates telavancin from other antibiotics.
Could you please comment on the importance of starting the appropriate initial empiric antibiotic?
That's a serious concern, particularly for this case, because the longer we wait, the longer we have an antibiotic on board that's not being effective in this case, with a prosthesis, with biofilm development, with Staph aureus, the more likely I believe that the outcome would not be good for the patient. I mean, we don't want this patient to have to go have another surgery and have the prosthesis removed. That's the worst case scenario for us. So what we want to do is we want to have an antibiotic started initially that'll be very effective. That didn't happen here. This patient had to go back to the OR. If telavancin was started initially, what we do know is it penetrates biofilm, it prevents biofilm formation, it diffuses well within biofilm, and it has activity against the bacteria within the biofilm, even vancomycin intermediate susceptible and dapto non-susceptible strains of Staph aureus. So when telavancin is used in a case like this, if it was used initially, maybe the patient wouldn't have went to the OR for a debridement because of the antibiotic would have worked. It would have worked against that non-dividing Staph aureus that's present in the biofilm.
So if that's the case, and it is so important to start initial effective therapy, why do so many institutions use vancomycin as their empiric gram-positive coverage?
That's a good question. You know, vancomycin is listed in many guidelines as initial first therapy for things. And I think it's more practice and habit and how you were trained and what you learned to do. People are just comfortable with vancomycin. It's often not a restricted antibiotic in the hospital. It's in a lot of like the protocols that are used within a hospital in order sets. So it's a familiarity thing. I don't think that in case like this, that the surgical team who started the vancomycin and cefepime for this patient was really thinking about biofilm and penetration and those type of matters. They thought, well, this is what we're going to put them on and we'll see what happens. But there's a comfort level with vancomycin. It's relatively inexpensive from an acquisition standpoint. We've been using it for a long period of time. So my feeling is that people are just comfortable with using vanco. That's what they know. That's how they were trained.
How does vancomycin compare to telavancin?
Well, vancomycin is a glycopeptide and telavancin is a lipoglycopeptide. They have some commonalities in their mechanism because they share a similar mechanism, inhibiting cell wall synthesis, but they're very different antibiotics because telavancin has another mechanism of action that separates it from vanco. If we look at susceptibilities of Staph aureus from published studies of isolates around the country, what we see is as an MIC creep develops with vancomycin for Staph aureus and particular strains, we don't see that with telavancin. So the mechanisms that Staph aureus uses to become less susceptible to vancomycin, the thicker cell wall and such, it doesn't apply with telavancin because televancin's second mechanism, destabilizing, depolarizing that cell membrane and resulting in a rapid cidal effect, vancomycin does not have that ability. So we have two mechanisms versus one, and it matters particularly with Staph aureus because of Staph's virulence, producing all these toxins and protein and non-protein factors that help it evade the immune system. There's a lot going on with Staph aureus that make it difficult to eradicate, relapses, non-dividing staph. We know that telavancin has activity against all these different Staph aureus mechanisms, even against the Staph aureus that are less susceptible to vanco.
This Infectious Insights series is brought to you by Cumberland Pharmaceuticals.